We are now on the record. Today is April 4th, 2018. Time is 3:01. My name is Michael Barankovich, a videographer for State Shorthand Reporting Service, Oakhurst, New Jersey. We are here to take the video deposition of Dr. Lance Markbreiter in the matter of Jill Consentino versus Tyler and Jonathan Sams, which is filed in the Superior Court of New Jersey, Monmouth County, docket number MON-L-3785-15. Would counsel please announce their appearance for the record?
I'm Thomas DeSeno, Chabelle, and many on behalf of the plaintiff, Jill Consentino.
Sean Doherty from the law offices of Pamela Hargrove for the defendant Tyler Sams.
Court reporter Stephanie Towns will swear in the witness.
Doctor, please raise your right hand. Do you solemnly swear the testimony you're about to give today is the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Good afternoon, Doctor.
Good afternoon.
Doctor, we're here today to take your deposition because of your operating schedule, your office schedule, and the court schedule. We usually can't coordinate all of those things at the same time, so we're here to take your videotape deposition here today, okay?
Yes.
I'm going to be asking you a number of questions, and some of those questions may require you to give us your medical opinion. I ask that if you were to give a medical opinion, that medical opinion be within a reasonable degree of medical probability. If you cannot give an opinion within a reasonable degree of medical probability, I ask that you do not do it, okay?
Yes.
All right. Doctor, can you state your name for the record?
Lance Markbreiter.
And doctor, can you give us your education, where you went to school?
Well, I grew up in central New Jersey. I graduated from high school and attended Rutgers University. I graduated in 1984 as a biochemical engineer. I took my engineering degree and chose to go into the field of medicine. I attended Yale Medical School in New Haven, Connecticut, and I was at Yale from 1984 to 1988 when I graduated with honors with my medical degree. I chose to take the engineering background and the medicine and go into the field of orthopedic surgery. I did my orthopedic residency training, a 5-year program, at Columbia Presbyterian Hospital in New York City, Columbia University, where I spent 5 years, where I trained to become an orthopedic surgeon. During that time, the 5th year, I did what's called sub-fellowships, particularly in the area of the shoulder, the hand, and the spine. Following that, I spent an additional year doing what's called a fellowship at the Hospital for Special Surgery, New York Hospital, part of Cornell, where I spent the year working on trauma of the lower extremity. This brings us to 1994. I passed all of my boards testing, I obtained all of my medical licensure, and I came back to my roots in New Jersey and joined 2 other doctors at a group called Shore Orthopedics and began practicing as an orthopedic surgeon the summer of 1994.
Doctor, you mentioned your residency at Columbia Presbyterian. Can you tell us a little bit more about that?
Well, a residency is where you learn how to become your field of specialty. In this case, I did an orthopedic residency. It's 5 years. Much like we see on television shows such as Grey's Anatomy, where you see the medical students, the residents. At Columbia, the first year, you're thrown into the operating room with the professors and you learn how to operate. You learn how to sew, you learn everything about surgery. The second year, you're now in with all the orthopedic surgeons. You're learning how to do hand surgery, back surgery, shoulder surgery. Most of that year, you're watching. Third year, hands-on. You're in the emergency room, trauma, taking care of fractures. By 4th year now, you're the one doing. You have 3 years under your belt. You're in the operating room, you're in the office, you're in the clinics, seeing patients, evaluating, doing the surgeries under the guidance of the professors. 5th year at Columbia, you're basically like an attending. An attending is a full-fledged doctor. We had admitting privileges. We admitted our own patients. We treated our own patients under the observation of the professors. That year, I did what's called mini fellowships. I did 4 years of 4 months of spine surgery, 4 months of hand surgery, and 4 months of shoulder surgery. After that, I went and did a fellowship at the Hospital for Special Surgery, mainly on the lower extremity, knees, foot, and ankle, something that I didn't have that extra specialty training at Columbia.
Doctor, are you board certified in orthopedics and orthopedic surgery?
Yes, I am.
What's board certification, doctor?
Well, in the field for orthopedic surgeons, for medical doctors, MDs, there's only one board of orthopedic surgeons. Basically, what it means is you've gone through medical school, you've obtained your medical license, passing all the medical boards, you did an orthopedic residency, you passed the written test, which was then given once a year in Chicago, still is. You were in practice for 2 years when you're considered board eligible, and then you have to go take an oral exam. So having passed everything, I started practice in '94. I was board eligible for 2 years, and then in '96 went back to Chicago, took an oral exam where you're tested on reading MRIs, reading EMGs, you're tested on examining patients. You have to bring with you X-rays, MRIs of all of the patients that you've treated, questioned about everything. I passed that in '96 and became a board certified orthopedic surgeon in 1996.
Do you have to be recertified every 10 years, doctor?
I became board certified in '96. In 1985, the board passed a law saying that it's only good for 10 years. So some of the more senior surgeons out there, if they became board certified from '85 earlier, it's good for life. After '85, it's good for only 10 years. So I became board certified in '96. I had to recertify in 2006, and I've recertified in 2016, July of 2016, which involves continued medical education classes over the 10-year period. It involves sending back all of your surgical records over a time frame and taking another test that involves diagnosing patients, reading MRIs, reading nerve studies, reading X-rays, reading CAT scans, and passing that test. So I passed that in 2016. So my current board certification is in orthopedic surgery is good through the end of 2026.
Now, doctor, are you affiliated with any hospitals?
I am affiliated with Monmouth Medical Center.
All right. And with that affiliation, do you do surgery there?
Yes, I do.
All right. And are you also involved in their teaching program with their residents?
Yes, Monmouth Medical Center. Nice secret in the area. It's the oldest, longest running orthopedic residency program in the state of New Jersey. We have 10 residents at any given time, and since 1994, I've been teaching residents. So I've taught well over 50 orthopedic surgeons going through their residency in that time. I also teach medical students. So when I step into Monmouth, I have medical students with me, I have residents with me, I teach there, I give lectures, and obviously when I'm operating and seeing patients, I'm educating them.
Now, doctor, you're licensed in the state of New Jersey to practice medicine.
Yes, I am.
And when were you so licensed?
I received that license. I applied in '94 when I took the job here. I believe after trying to rush things because the state of New Jersey doesn't move quickly, I was able to obtain that. I believe it was by mid-June of '94, and I started working the Monday after the 4th of July in 1994.
Okay. At this time, I would move the doctor as an expert in orthopedics and orthopedic surgery.
No objection.
Okay, thank you. Now, doctor, at our request, did you have the opportunity to examine the plaintiff here, Jill Consentino?
Yes, I did.
And what's involved in your examination, doctor? When she comes to your office, what happens?
Well, just like any patient that I'm treating, I take a history. I talk to the patient. Here I spoke to Jill. She was sent to me specifically to talk to her about an accident that happened a few years earlier, December 21st, 2014. So I took a history from her. I have to say she was not a very good historian. She did not recall names of doctors or, in fact, specifics of any treatment. However, I was also supplied the records. So I had an opportunity to review the records with her. I had an opportunity to talk to her, take a history, go over what her complaints were, what happened in the accident, what the complaints were, what the treatment was, and what her current complaints and issues were. In addition, I then had the opportunity to hands-on do a physical examination, correlate her complaints with my exam. In addition, I was supplied other medical records that are objective studies. I was supplied x-rays and MRIs, which I also had an opportunity to personally review. So I was able to talk to the patient, assist my history with the actual medical records of doctors, review them with the patient, perform an exam, look at x-rays, look at MRIs, review actually a nerve test that she had, and review the treatment she received, and then reach conclusions regarding diagnosis, causality, prognosis, and permanency.
Okay. Now, doctor, before we talk about history and your examination, let me ask you a little bit about subjective and objective findings. Are they important in your evaluation?
Yes, they are.
And what's the difference between a subjective finding and an objective finding, and why is it important?
Well, basically, subjective is something someone tells you. Subjective would be if a patient says, for example, my neck hurts, my arm hurts, I have pain. It's something that only the patient can tell you. There's no test for it. There's no standard test that we have to say, what is the patient's pain level? Everybody's perception of pain is also quite different. An objective test is something that doesn't rely on the patients telling you how they feel. For example, if someone was to fall down and break their wrist and I get an x-ray and I see a broken bone, that's an objective study. If someone has an MRI and I can see a fracture or a disc herniation, that's an objective study. It's something that I can see without the patient telling me their complaints.
And how does that work with, or how does that mesh with your examination?
Well, my examination is made up of different parts. Number one, it is the patient's subjective complaints. The patient tells me what bothers her. For example, in this case, she told me that she had tightness and pain in the back of her head and her neck, diffusely around the back of the shoulders and the upper part of her thoracic spine. That's subjective. It's what the patient tells you. Objective is what you find, one, on examination, two, on objective studies. We perform objective studies, such as x-rays and MRIs and nerve tests, for the purpose of determining what injuries are. So objective studies are what we rely on to make diagnoses. For example, a patient may come in and say, I feel lightheaded, I think that I'm diabetic. But then you do a blood test and they're not diabetic, their sugars are normal. The blood test is objective. Even though the patient may say, I think I have this problem, blood test is objective.
Okay. Now, you started with your history with this patient, is that right, the plaintiff?
That is correct.
All right. What was important about the history in your evaluation of her?
Well, the patient, what was important is the patient was involved in a motor vehicle incident. She was stopped at a light when she was rear-ended, and after that, the medical record says that she had sustained an injury to the neck in the upper thoracic area. She went to a chiropractor. She had very little treatment. She saw a chiropractor, she saw a pain management doctor who gave her injections on 2 occasions, and in fact, she told me she did extremely well. She told me that she had an injection in her neck and back, and basically with the steroid, she felt fantastic for about 9 months and really good for about a year. She also told me that following that, she moved to Las Vegas. She was working in Vegas and noted that she did not have any medical treatment after she went to Vegas. So what's important in the history is that she did sustain an injury from an accident. She did have treatment. That treatment helped her a great deal, and she didn't have any more treatment for it. And it wasn't until I was evaluating her that she came in and explaining to me some of her ongoing complaints that she was having, although after her treatment she told me 9 months of excellent relief and symptoms had resolved.
Okay. Now, doctor, did you have occasion to ask her about any prior problems that she had?
Yes.
And what was the result of that question? What did she tell you?
Well, she had told me that in the past she had gone to a chiropractor. She was vague and did not recall the details of what she received treatment for, but she did tell me that she was a singer, she was a performer. I remember her well because she told me that she grew up in the age of the divas, and she was one of the diva singers. And as a result of being on stage, she often had aches and pains in her neck and back, and she went to the chiropractor who helped her because it helped her with her performance, and in fact she told me it helped her with her singing voice to be adjusted, especially with the tightness that she had.
You reviewed some medical records from the hospital, is that correct?
Yes, she went to the emergency room, and I did review those records.
And when you reviewed those records, did she have an x-ray to the neck?
Yes, when she went to the hospital, she had one x-ray which was done of the neck at Ocean Medical Center.
And did you have the opportunity to review that x-ray?
Yes, I personally reviewed that x-ray supplied to me on disc here.
All right, and what were your findings as to that x-ray, doctor?
Basically, what I found was in the central portion of her neck. Now, the neck has 7 bones. Cervical spine, C1 down to C7, we label them. The central portion, which was C4, C5, and C6, had a significant amount of what we call degeneration, had a significant amount of arthritis, mainly in what's called the facet joints. The facet joints are where the bones sit upon each other, where the actual joint is between the 2 bones. And there was arthritis there with what's called hypertrophy, which is swelling and inflammation of the joints. I found that it was actually quite significant, more than one would expect for her stated age. At the time of that x-ray, she was 45 years old. Her neck in that area looked like the spine of a 65-year-old.
Do the discs have anything to do with the facet joints, doctor?
No, the discs on the x-ray appeared fairly normal. Her spaces were maintained. The discs are in the front, and the joints are in the back. It's almost like if you have a tricycle, 3 wheels. You have the front wheel, which would be the disc, and then you have the 2 little wheels in the back, which would be the facet joints. So she had problems in the facet joint area. X-rays don't show discs very well. They show the space. It's an open space. MRIs show discs. But on the x-ray, I was able to see the degeneration, which was significant at those 2 levels, particularly C4, C5, and C5, C6, which is the central portion of the cervical spine. The x-ray doesn't show the discs, but the spaces were maintained.
Did she have an x-ray of her low back at the hospital?
No, when she went to the hospital, she had no complaints of her low back. When I reviewed the actual physician records, it said that there was no low back problems. In fact, it gave all the negatives. Her only complaints were neck and upper back, and she described that as really the area behind the chest. There was no complaints of the low back, and they did not do, they did an examination. The review of systems said there was no pain in the low back. It was negative. The exam of the back was normal. So appropriately, no x-ray was done.
Did they ask her, or did they report that she reported to them that there was a loss of consciousness?
No, there was no loss of consciousness. The emergency room record said that there was no dizziness, no headaches, no loss of consciousness.
Okay. You had the opportunity to review the reports or the records of her chiropractor, is that right?
Yes, that is correct.
And did you also have the opportunity to see Dr. Bleiweiss's records?
Yes, I had the opportunity to see the chiropractor as well as, I believe it was 2 office visits with Dr. Bleiweiss and 2 procedures that he performed, injections.
Okay. And then you also had to review the record of Dr. Landa, is that correct?
Yes, she saw Dr. Landa on 1 occasion back in April of 2015, and I had the opportunity to review his office note.
Okay. Now, you also had the opportunity, I believe you said, to review the MRI studies in regard to this case, is that correct?
Yes, absolutely.
All right, let's talk about the physical examination first, doctor, and then let's talk about the MRI studies, and we'll show those to the jury, okay?
Okay, very good.
All right, you did a physical examination of the plaintiff, is that correct?
Yes, I did.
What parts of her body did you examine?
Well, I examined the parts that she had ongoing complaints about, the parts that she said, this is where I have some symptoms. Basically, she said that her symptoms were in the back of her head, her neck, and her upper thoracic area behind her chest. She noted the pain in tightness and muscle aches out behind her shoulders. In addition, she said she had some low back discomfort. She had no radiculopathy, and what radiculopathy is pain that radiates down the arms. So she had no pain going into the arms, no pain going into her legs. So on examination, I examined her neck area, and I noted that when I examined it, she complained that there was pain to my putting pressure and feeling her neck. It was not only in the neck, but all of the muscles, shoulder muscles, the trapezius, the traps which come out to the shoulder, as well as coming down. So she had tenderness in the neck, all along here, out here, out here, to my palpation. The muscles were tight, and she complained that she had tightness in her muscles. In fact, she told me that she was very happy in Vegas because she had tightness in the muscles, and she would often tighten up, and she would go for massages in Vegas. She noted that in Vegas, massages were inexpensive, only cost her $20. So that's what I found up top. Now, I tested for any types of nerve compression. For example, a Sperling's test, which was negative. That's a test we do for nerve compression, for any disc herniation. She had no radiculopathy into her arms, both subjectively and objectively, meaning I didn't find any radiculopathy on my exam, normal strength, normal sensation. In addition, she didn't have any complaints of radiculopathy. Same thing in the low back. When I examined her low back, she had some tenderness right down in the center, the small of her back. Right in the midline, there was a negative straight leg raise. She had normal range of motion of her low back, normal range of motion of the lower extremities, normal sensory feeling, normal strength, and no subjective or objective findings of radiculopathy.
Doctor, is tenderness and tightness subjective?
Yes, it is.
All right. It's not an objective finding.
No, when I examine somebody and they tell me that that area is tender, I have to rely on the patient telling me what's tender.
In your report on page 5, you indicate that there was a negative Sperling's test.
Yes.
What is a Sperling's test, and why is that important?
Well, in this case, it's not very important because the patient's not complaining of radiculopathy. But a Sperling's test is an objective study or an objective test we do to test for radiculopathy. So the head is pressed down, compression testing. The head is rotated and turned, and we compress the exiting nerve root. Now, if indeed there was compression of the nerve root, this would aggravate it and cause shooting pain down the arm. The patient had a negative Sperling's test, which shows that there was no signs of any nerve compression. So she didn't have complaints of nerve compression, and when we did a provocative test to try to provoke it, she didn't have any findings. So it shows that there's no nerve damage, there's no discs pressing against her nerve.
Let's go to the lumbar spine and the testing you did there, doctor. I see from your report you did you did a straight leg raising test. Is that correct?
That is correct.
And the finding there was negative. Is that correct?
Right, and the straight leg raise is the equivalent to the Sperling's test in the lower extremity. Once again, a tension sign. If you have pinching of a nerve, disc herniation against a nerve, it will cause radicular pain to shoot down the leg. You reproduce it by doing a provocative measure, dorsiflexing the ankle, extending the knee, lifting the leg up, and you reproduce the pain. She did not have complaints of pain going down her leg subjectively, and she did not have any objective findings with no positive findings. The straight leg raise was negative.
You also did a neurological evaluation on the lower extremities. Is that correct?
Yes, I did.
And that was a sensory finding and a reflex finding. Is that correct? Or a motor finding?
Well, it was motor. It was basically muscle and sensation, all of which were normal. I didn't do tendons, reflexes, because if you don't have any radiculopathy and you don't have any complaints of neurologic complaints, there's no reason to do that.
Okay. Now, you had the opportunity to review first an EMG study. Is that correct?
Yes, correct.
What's an EMG study, doctor?
EMG stands for electromyogram. It is generally done together with a nerve conduction velocity. So an EMG nerve conduction velocity is an objective study that is done to determine if there's any nerve damage.
And when was that done in this case?
It appears that it was done on March 11th, 2015.
And what were your findings as to the EMG, doctor?
When I reviewed the EMG, it showed that there was some slowing of the conduction across the median nerve at the palm of both hands, at the wrist. There was a little bit of slowing of the amplitude in the wrist associated with the muscle in the thumb, known as the abductor pollicis brevis. This was consistent with some damage to the median nerve at the wrist, which is what one sees in carpal tunnel syndrome.
And did she have carpal tunnel syndrome before this accident?
Yes, by history, I reviewed with her. She had a history of carpal tunnel syndrome. In fact, had previous surgery in both wrists for her carpal tunnel. And in fact, when I did examine her, it's unrelated to this accident, but she did have scars from the carpal tunnel surgery, which is unrelated to this accident, was something previous.
Can you have surgery and still have this carpal tunnel finding?
Well, the EMGs are sensitive. When you have years of compression of your nerve, surgery will release it and help improve symptoms. But the EMG picks up, and it's a subtle finding. It's not severe, but does pick up that there's damage to the median nerve. So the EMG clearly shows that the patient did have a history of some carpal tunnel syndrome.
Anything else?
No, nothing else.
Okay. Now, you also did a review of the MRI studies, the neck and the low back. Is that correct?
I did, yes.
What's an MRI, doctor?
An MRI is a magnetic resonance imaging. It's a nice tool that basically shows us the soft tissues inside the body. So X-rays show us bone. CAT scans show us bone. An MRI shows us soft tissue, so it's great to look at the brain and the discs inside the body. Specifically, it's a giant magnet. And very quickly, our body is made up almost all of water. Water, the molecule is H2O, 2 hydrogens, 1 oxygen. Hydrogen is the simplest atom, has 1 electron. What happens is the magnet is turned on, and you have this electron floating around the nucleus, this being the electron, and it's pulled up into a higher orbital by the magnet. Then the magnet shuts off, and the electron falls down back to the lower orbit. It gives off a packet of energy. Just like this gave off sound, it gives off what's called a photon, little tiny particle of light. A big screen, a receiver picks it up, much like a television screen, goes into a computer, and it gives us a photograph of the inside of the body in black and white based on water content. Depending on the spin of the magnet, we can get such that water is white or water is black, opposite for fat, black and white, and it gives us images of the inside of the body.
Okay. Let's go off the record for a minute. Let's set up the MRI study so you can show that to the jury, and
Time.
we'll move on, do that.
Time is now 3:29, going off the video record. Time is now 3:33, back on the video record.
All right, doctor, let's take a look at the film we have here. Can we identify whose film this is and the date?
Well, this is an MRI of Jillian Consentino.